So usually we let people kind of filter in closer to maybe 2 minutes after 3.
Sure.
We have a few lab meetings that kind of go right up until 3.
It's just still so nice that we get to do this across the country without, going anywhere.
Yeah, we I know I actually just went and did one of these for another institution, and it's an hour-long talk, and you leave the day before, and then you fly in and you hope that you
Yeah.
make it on time, and then you're there for the whole day and you don't get home until midnight. So
Which, yeah, it's nice sometimes to be in person, but it's nice to have the Zoom option too, or the
yeah, I think we're going to
Teams
stick with
option.
this format. One thing that works for us is it's been hard, when we've got 4 partners that are spread, all over Nashville and now soon in Memphis as well,
Oh,
to get everybody in the same room together too.
yeah.
Particularly when there's, issues with parking and driving over, and so yeah, this has worked out pretty well for our group. This UCSF, I know Peter runs a seminar series as well that I've attended before. Peter Hunt, for more for laboratory science, I think. But I think you all have a couple different CFAR seminars series.
Oh, yeah, we do. And Wednesday mornings usually. So
Okay.
we have, the different cores do their own series and then the overall CFAR, and there's a lot.
Okay. Yeah, I think we've tried out different time slots. It's hard to find something that works for everyone, particularly when we've got a lot of clinicians as well.
Yep.
So which is why we have the recorded, because I think sometimes we have more people watching recorded than we do live. But I think the most important thing though is just to get speakers in and get the information out to our members. Yeah, that's good. Looks like now folks are filtering in. Let's give it a few more moments.
Are you part of the MASNU P60?
You mean glider? I think that's the
Yes, I think that's
abbreviation.
one of the studies of it. Yeah. I forget the
No,
overall
but
name.
Kurt Gabriel, who's on the call right now, does quite a bit with Matt
Oh, great.
around the microbiome and
Mhm.
liver disease as well.
Yeah.
So no, but I mean it'll be. I think that the clinical science core, April Pettit is our director, and she may be joining in just a minute. She will be. I would assume they'll be recruiting for the study. So currently we're
Hmm.
recruiting his meta study, which I'm sure you know all about. Started in St. Petersburg
Yeah. Yeah.
until what happened in Ukraine, and then obviously it wasn't so easy to collaborate with St. Petersburg. So he
Hmm.
moved that to the U.S., and we're recruiting that in Nashville.
Right.
And then the clinical science core will start recruiting glider as well. Sounds like a fascinating
That's great.
study.
Yeah. Yeah. Very exciting.
Trying to decide what you can't use GLP-1 agonists to treat.
Underweight.
Yeah, and that's probably about right. Who are not diabetic enough. Okay, why don't we go ahead and get started? I usually have folks still continuing to filter in, but I want to make sure we leave enough time for the talk, as well as question and answer sessions. So I'll just go ahead and welcome everyone to the Tennessee CFAR monthly seminar series, and thank you all for joining. We are still in our series of nationally recognized external speakers that we've brought in, and today we're absolutely delighted to have Dr. Judy Hahn joining us from University of California, San Francisco, and the UCSF CFAR as well. Dr. Hahn's a professor of medicine in the HIV, ID, and Global Medicine Division at UCSF, and she is an epidemiologist with extensive experience studying behavioral and biological intersections of alcohol use and infectious diseases. And I should state that she's been a longtime collaborator of people here at Vanderbilt, including Matt Freiberg, in the Division of Cardiology. And Dr. Hahn's been a pioneer in the use of biomarkers for the objective measurement of alcohol use, and also with the purpose of improving both research and clinical care. Over the past 15 years, she's been the PI on multiple NIH grants. She is the author of over 200 articles and has also received multiple mentoring awards. And most recently, she's MPI of a new NIH-funded P60 Center for Alcohol and HIV Innovations and Biomarker Research, with the abbreviation of CALIBR, that will leverage advances in alcohol measurement technology to address the complex relations between alcohol use and HIV, particularly among populations that are disproportionately affected by both of those conditions. So her talk will be called Using Alcohol Biomarkers to Understand and Intervene on the Role of Alcohol Use on HIV, TB, and Liver Disease. And Dr. Hahn has said that if the questions come up during the talk, there's no need to wait for the end. People can just use the raise hand feature and we'll go from there. So Dr. Hahn, thank you so much for joining us today. And you should be able to share your slides.
Okay, I'll give it a go. Thank you. Thanks for having me. And it's a pleasure to talk about things that are near and dear to my heart. And here they come. Okay, and I have tried to make this talk not too long, so because I hear that there's always good discussion. So I'm very happy to, hear your thoughts and answer questions, but discuss too, because, nothing is solved yet, unfortunately. Advance. Okay, so the rough outline of what I want to discuss is just to remind you why alcohol use matters in HIV, ponder if we're measuring alcohol use accurately. I will talk briefly about alcohol biomarkers, especially PEth. And if you have questions about that, I'm very happy to answer. I could talk for an hour about alcohol biomarkers themselves, but that's not the main focus. I also want to discuss alcohol use and major comorbidities, including TB and liver disease, and then switch to what we know about alcohol interventions for people with HIV with and without alcohol biomarkers, and talk a little bit about what I think, at least my future directions are, but happy to, what I think where the field maybe should move, and, get others' thoughts on that as well. So just to remind you of the overview of alcohol and HIV, I'm first going to start with just alcohol. Alcohol use worldwide has kind of an interesting distribution. If you look at the picture on the left, you see that in most of the Western and higher developed countries, most people drink alcohol. The blue is the higher proportion of people who drink any alcohol. And the yellow is countries that are predominantly Muslim, and there are countries in Africa who have, not everybody drinks alcohol. But then if you shift to the right, you see among the people who drink alcohol, the distribution of people who have had a heavy drinking session in the past 30 days. And there you see a lot of heavy drinking in sub-Saharan Africa. And this is sort of the typical pattern of alcohol use worldwide. Higher developed countries have more overall alcohol use. Lower developed countries and countries with, certain populations may have, not everyone drinks, but the people who do drink tend to have very more risky drinking patterns. And if you overlay that heavy drinking diagram on the right with the map on the left of HIV, you see, of course, a high intersection of alcohol use and HIV prevalence in sub-Saharan Africa. And that is where a lot of my research has focused. Just giving the basic numbers, there was a meta-analysis from a few years ago that determined that approximately, obviously, 22% of people with HIV in sub-Saharan Africa had unhealthy alcohol use. And then some recent findings from the US-based CNIX database showed that 17.5% of people with HIV in the CNIX sites had unhealthy alcohol use. So in thinking about the problem of alcohol use, we saw this overlap and thought, wow, there's a lot of reasons why alcohol use can be problematic in HIV. It can affect really all the steps of the continuum, the behavior aspects and the biological aspects, from the sexual risk behavior to higher risk for acquisition, lower risk for lower access to diagnosis, receipt of antiretrovirals, lower retention and care, likely lower adherence, and leading to poor viral suppression. And then, of course, that would lead to onward transmission. And in addition, on top of that, there's many infections and conditions that are affected by alcohol use that are also really bad in HIV, including TB, viral hepatitis, liver disease, intimate partner violence, tobacco, other substance use, mental health, cognitive health, declines, inflammation, cardiovascular disease, and cancer. And maybe I've left some out, maybe also structural factors as well, I would say. So there's a lot to think about with alcohol and HIV, a lot of reasons to be concerned. And people have been looking at that. In 2014, Emily Williams at the VA looked at how alcohol use affects the HIV care cascade in detail, and you can see that the bars going from left to right within each graph is lower, no drinking all the way up to very high level alcohol use. And there's a dose response seen between the level of alcohol use and the poor outcome, or the lack of the good outcome, not being engaged in care, less likely to be treated with ART, and less likely to be virally suppressed as you go from left to right in this graph. We had some data from sub-Saharan Africa, from Uganda and Kenya, a 10,000 person study. People engaged in the SEARCH study, which is a very large community-based HIV study in those countries, and found similar patterns. Early on too, in thinking about alcohol, HIV, a really important study was conducted by Christian Hendershot, where he did a meta-analysis of the studies that had alcohol use and ART adherence, and found that really any alcohol use was associated with poor adherence, with a odds ratio of 0.55 for adherence with in the 40 studies. These studies were primarily conducted in the US. So more recently, Jen Veloza did an updated meta-analysis looking at studies in sub-Saharan Africa and found 23 studies, and found she used the flip of the outcome. So she was looking at non-adherence, and there the odds ratio of the alcohol use predicting non-adherence or being associated with non-adherence was over 2. So very similar results, very consistent. So those are things that are fairly well established about alcohol use and HIV. But the question is, if alcohol use is so important, why haven't we made more progress? And one possibility that came to me in my work is that we may not be measuring alcohol use accurately. And how we came across this observation was that we started looking at alcohol use in people starting antiretroviral therapy in Southwest Uganda. My mentor was David Bangsberg, and he was amassing a cohort of 500 people initiating ART in Southwest Uganda in the early 2000s. And he was really looking at, can people in Africa adhere to antiretrovirals, which was surprisingly a controversial issue. The regimens were fairly complex. There was the refrigeration issues, cold chain issues, et cetera. And so he started a cohort to find out if they could, which the answer is, of course, yes. However, we also became interested in the issue of alcohol use in Uganda based on what I said before about how there's this concentration of high-risk drinking in places in sub-Saharan Africa where there's also a lot of HIV. So in his cohort of 500 people, we took a look at the data and found that at their baseline visit when they were starting ART, 22% reported prior year alcohol use. But then we started looking at, they had follow-up visits over 3 years. And at the later visits, 83% suddenly of those people who had reported alcohol use baseline reported abstinence. And 77% of them reported sustained abstinence over a year. So this was a pretty exciting finding. And it could be that, when you get on antiretroviral therapy, you get a little bit of counseling, especially then, maybe not a whole lot of counseling about alcohol use, but it was mentioned. maybe that was a really effective intervention, or perhaps there may be some issues with reporting. Given the ubiquity of alcohol use in that area, we were a bit suspicious. So and then in stepping back and thinking about self-report, what are the issues with self-report? And this is really relevant to really all research that uses self-report and clinical care that uses self-report. So there's the recall issue. Someone might try to answer the questions about alcohol use well, but it's a little bit hard to remember, especially with alcohol use. There's unknown drink volume. A lot of times people socially share alcohol. And so you don't really know, your glass gets refilled or you're drinking, from the same bottle. You're not really watching how many glasses you're drinking, or in the case of the picture on the left, that's a traditional beverage that, everyone's around the same pot drinking from straws. The other thing is, drink sizes really vary. You often probably know that you go to certain bars where, the pours are more generous, or the drinks are stronger, or the drinks are less strong. So there's that variability. And then the big bugaboo, I think, is social desirability, that it's, really challenging for people to want to, maybe feel comfortable enough if they feel there's some reason why they shouldn't be reporting their level of alcohol use. In addition, it's really hard to predict when the self-report will be problematic. If it's not problematic, self-report is great, right? It's cheap, it's fast, it's easy, but it's hard to know when you'll have problems with self-report. So we began thinking about what we could do to get objective measurements of alcohol use. And that's where the alcohol biomarkers came in. So the first biomarker I'm going to talk about is phosphatidylethanol, and that is the one that I use the most, but there are others, and they have their important uses. So phosphatidylethanol, or we call it PEth, I sometimes hear people call it PEth. It's an abnormal phospholipid that's formed only in the presence of alcohol. It has a nice long half-life, so it reflects drinking over the prior 2 to 3 weeks, and sometimes 2 to 4 weeks. It's been shown to have pretty good sensitivity and specificity for any drinking and for unhealthy drinking and for even high-risk drinking. That's based on good correlations with total grams of alcohol. It has good correlations with total grams of alcohol consumed over the prior 2 to 3 weeks. It's currently measured in whole blood or dried blood spots, meaning, unfortunately, we can't go back into all our great serum and plasma banks and measure it. It's whole blood, dried blood spots. And it uses liquid chromatography and tandem mass spectrometry, which is reasonably expensive. So that is the downside to it. And I would mention that there is some interperson variability, and I think that's one of the open questions about it, but I'll also show you how useful it's been so far. So there's the PEth molecule, there's the dried blood spot, getting the blood spots. When I first started looking into what biomarker to use, I found phosphatidylethanol or PEth in the literature, but it hadn't really been very well validated, and it really had not been looked at in people with HIV or people in Africa. So we set out and did a validation study to look at how this biomarker did. And rather than, you need a gold standard to test against, the previous studies do things like where they have people come to their facility and stay in their facility for several days. That would, and have, standard doses of alcohol. We weren't going to do that, but what we did do is we had as our gold standard daily breathalyzer testing, where the research assistants went on motorcycle to the locations and did the breathalyzer testing. We had a range of people with very heavy alcohol use to people without any alcohol use. They got their breathalyzers at home or other places, but they did that every day for 21 days as our gold standard for alcohol use. And we did confirm that in this population that the PEth was sensitive and specific for any and for heavy alcohol consumption. You can see our ROC curve there. Just to mention other biomarkers, other objective markers, breathalyzer testing is a good measure and used in certain circumstances. Nowadays, you can get cell phone prompts to have someone do a breathalyzer test. There are equipment and companies that use a facial recognition program as well to make sure that is the same person doing the breathalyzer. There's also the ankle worn and the wrist worn monitors that measure the transdermal alcohol that's excreted through the skin, and that gives you a near continuous measure. And both these two things are prospective. You meet with a person, you put it on, you see what they're drinking sort of in the future as they're wearing it or blowing into the breathalyzer. Whereas the PEth biomarker and the other biomarkers look backwards and say, okay, I got you today, I drew your blood, and this is what the level that reflects what you were drinking in the past. So that's more retrospective. Ethylglucuronide is another biomarker that's quite useful. It's found in hair, and that has an even longer half-life. So that reflects 2 or 3 months heavy drinking. It's not so good at picking up sort of any drinking. And then ethylglucuronide in urine detects any drinking in the past 1 or 2 days. So it gives you a little bit of a longer window compared to, say, breath or blood alcohol. In addition, my team, and I'm sure others, have been working on machine learning models to use all the available laboratory values. Alcohol affects many organs in the body, as you know, so they should, using those together could help as a sort of, I would call it sort of a pseudo biomarker, just getting a score. And we've been working on that to some degree of success. Okay, but back to PEth. What did we learn when we started looking at these biomarkers? We learned that we could use PEth in our people with HIV. So then we want to know, are we measuring alcohol use enough to understand its impact on HIV outcomes? And how does it relate to patterns of alcohol use in HIV care, given that we were seeing all that reduction in alcohol use in that cohort that I mentioned before? So before we even got to doing the biomarker testing, we found this interesting result where we found that we were using that base study that I said before, people entering HIV care, and we wanted to recruit them for a small sub-study of biomarkers. And so on the same day they were referred to our study, they underwent our informed consent, where we said we're going to draw, I think it was blood and urine and maybe even hair for alcohol biomarkers. And then we were going to study ART adherence and viral suppression, I think. But even before we got there, what we observed in our data is that the self-report we did a second interview, and just on the same day interview, the self-report of alcohol use doubled. And all we had done was say we were going to collect biomarkers. So we went from about 20% to almost 40% saying that they had had any alcohol use in the prior 3 months. And that jump was much more extreme in women compared to men. And I wouldn't say that generalizes to everybody, but that was the case in that cohort. And then we've been using biomarkers in various populations, and we found underreport by using the biomarkers in some, but not all of our studies. So this is looking at people reporting any alcohol use and how many more are PEth positive, having a detectable level of PEth of greater than or equal to 8 nanograms per mL. And you see that in our US-based studies, at least in this set, we didn't see a whole lot of improvement when we added PEth, but in our Ugandan and South African studies conducted in Uganda and South Africa, we did see a lot more, as denoted by the yellow bars. We had similar findings when we looked at higher PEth levels and levels that we were considering indicative of unhealthy alcohol use, and we used a 50 nanogram per ml cutoff there. And we actually found pretty high levels of that additional PEth when we looked at women with and at risk for HIV in San Francisco, and also again in the Uganda and South Africa samples. And going to an even higher level of having a PEth of 200 nanograms per ml or more, which is considered very high alcohol use. A high proportion, almost a quarter of them, in people in Uganda and the US were actually reporting fairly low risk alcohol use, so that their audit C-score was less than 6, which is 6 is a cutoff for a very high level. So they were reporting either no or moderate alcohol use when their PEth level was really quite high. So after validating the PEth and seeing that, yes, we do have underreport, we wanted to go back and look at the patterns. What is happening when people are getting into HIV care? So we were able to funded to recruit a new cohort of people entering HIV care in Uganda. This is, we wanted to look at people who were probably drinking alcohol. So we recruited the people who had reported any prior year alcohol consumption on clinic entry. this clinic was actually doing the audit at entry into care. And then we followed them quarterly for a year. And we see by self-report, using the audit, see the alcohol use consumption, especially the people not on ART, the blue line is going down. The people on ART, it's fairly stable, but it's low. But when we added in the biomarker, we had a huge difference in the amount of unhealthy alcohol use we were detecting using a PEth level of 50 or more, finding that a very, almost 70%, 60 or 70% had this unhealthy drinking among these people who had already reported some drinking. And then the patterns were kind of interesting. The people who got on ART, there was a reduction at the start of ART, but as you can see from the red line, it started to creep back up. And the people who were not on ART stayed fairly stable, or maybe there was a little bit of a reduction in drinking, maybe in anticipation of starting ART. But it's definitely a different set of patterns for people compared to using the PEth compared to the self-report. And it did confirm that, yes, alcohol use, unfortunately, is an ongoing issue in HIV care. A little bit of counseling at baseline is not necessarily going to solve the problem. So we need to think about solutions for that, even for patients who are well engaged in care. So in summary, we found for this that self-report can increase after informed consent. But even those studies where I was showing the PEth levels, the underreporting, there was still underreporting happening in these. And these are research studies. Imagine the difference between the research studies and actual clinical care. We found that PEth increased detection at all levels of alcohol use across various settings, although there's some variability. Like I said before, you can't really predict who might underreport. And this does highlight the need to that there is important amounts of alcohol use even within clinical care. Did I see a hand? If you had any questions, call out before I jump into my next. Okay. Now I'm going to move into discussing, what we're finding when we start to use PEth, looking at HIV comorbidities. We've worked on, a variety of things, not the whole landscape, but mostly focused on TB disease in Uganda and starting to focus on liver disease and have some future work in the liver disease area. So TB is the leading cause of mortality for people with HIV worldwide. And alcohol use has been considered associated with incident TB disease. That's not something new. However, in around 2020, I'm actually not sure the year, the World Health Organization started recommending that isoniazid to prevent progression to active TB disease be given to all people with HIV in high TB settings, high incidence TB incidence settings, including Uganda. So we start to do work around that area. We had conducted two fairly large studies where we had people with HIV. We oversampled for people with high risk alcohol use or any alcohol use, and we were screening for latent TB infection. So we had 998 people that we had already studied. We knew how much alcohol they were drinking based on the biomarkers. We knew that they had latent TB, and actually in these studies, we gave them 6 months of INH to prevent the TB progression. So several years later, this was in around 2017, in around 2022, we were actually funded to find these people doing chart reviews and see if they actually developed active TB disease. So we were able to do chart reviews and have over almost 4,000 person years of follow-up and see how many developed active TB. And there were 23 cases that we found. And when we looked by our alcohol use that we had previously measured, that's the red line, and we found that the high-risk alcohol use was associated with higher risk of TB disease. And this is active TB after already receiving INH. So the alcohol use, it remains a problem, not just, that INH didn't really solve the problem. It's still a problem whether or not you've received INH. So here's our we did a multivariable model looking at the high-risk alcohol use, and we controlled for body mass index, cigarette smoking, and viral non-suppression. We did actually see also an association with viral non-suppression being associated with incident TB disease. But I would mention that there was a small, I think only about 6 or 7% were virally non-suppressed. So the bulk of even though it's a higher hazard ratio, there's more people in the high-risk alcohol use category who are at risk. Okay, question.
Judy, yeah. Kelly Dooley put a question in the chat.
Oh, great.
I don't know if you can see it, I'll just read it. It says, was the TB from the alcohol effect directly, or was it related to alcohol effects on adherence and side effects?
Yes. We have found that in other research that alcohol use is associated with poor isoniazid adherence, but because we were the ones giving them the INH, we actually did MEMS caps, and so we measured the adherence, and you can see at the bottom of the slide, we tried to adjust for adherence and it didn't do anything. We did a dichotomous variable, we did a continuous variable, we didn't see the adherence having the effect. So it's possible that it wasn't the INH, had nothing to do with an INH, that they got re-exposed in those 3 years since we saw them last and got new TB. Without doing sort of molecular studies, we can't really tell if it's reactivation versus new infection.
Thank you. That's super.
Okay, great, thanks. And last time I presented this, that was the same question I got. And yeah, I mean, it may be that there's, more suppressive therapies that could be given, but yeah, it was interesting that we thought the adherence might play a role and it really didn't.
Yeah, and it could be just that it has its own independent effect on like the immune system's ability to contribute to taking care of the latent TB and not letting it progress. But it's interesting.
Yep.
So yeah, thanks.
Yeah. Thank you. Okay, so now I'm going to move on to another important comorbidity, more, I would say, prevalent in the higher resource settings, and that's the liver disease. And liver disease is extremely common in the form of steatotic liver disease. I'm probably speaking to people who know all about it, but very common in the U.S., and it's in people with HIV and people without HIV. And it's usually asymptomatic or presents with, non-specific symptoms like fatigue. So it's usually recognized on liver tests. And it is reversible, but if it's not treated, it does increase the risk of more severe liver conditions. What's interesting in this field is that I always find this fascinating. They categorize steatotic liver disease by your cardiometabolic factors and your self-reported alcohol use. And they have found that people with a higher level of alcohol use have higher risk of progression to the more severe liver disease. So I guess that's the reason for doing that, because they give these names that have to do with how much you're drinking. But it's always been based on self-report. More recently, the liver field has discovered PEth testing, and recent articles from the San Diego cohort, I believe, and from Sweden found that when they looked at the PEth testing compared to what they had, by self-report, that about 20% of their patients were miscategorized. And so that would lead to under-treatment of the alcohol use, the underlying driver of one of the underlying drivers of the liver disease, and would also really maybe not highlight the severity, the potential for rapid progression if they're not recognizing the alcohol use. So that is problematic. Given those data, we looked at what data we had, and we had an analysis for looking at a different question, but we had 12 studies that had measured phosphatidylethanol and all the liver enzymes that are needed for the FIB-4 marker, which is a non-invasive marker of liver disease risk. So we conducted an analysis of looking at the self-report and the PEth in relationship to the FIB-4 score, cutting off at 2.67, which is considered high risk for fibrosis. So when we looked at, on the left there is our modeling. When we just looked at PEth alone, using it as a continuous measure, we found it was a significant predictor. We found that audit C, using that as a continuous variable, was a significant predictor. But when we put them together in the model, it was the PEth that was the stronger predictor, and then FIB4 compared to the audit C. So suggesting that it is possible that PEth is indicating the biologic harm of the alcohol use more accurately than just how much you're consuming, and or there's the possibility that there's self-report is problematic, as mentioned prior. So given these findings, and together with the fact that most studies of liver disease have excluded persons with HIV and have excluded persons with high-risk alcohol consumption and have relied on self-report, we sought to understand the role together, the combined role of alcohol use and HIV on liver outcomes, including steatohepatitis and fibrosis, and to examine the biologic mechanisms that may be on that pathway, including gut microbial translocation and aberrant DNA methylation. And this is being conducted leveraging the MaxWise combined cohort study, which is a study of about 6,000 persons with and without HIV. It's the longest running cohort study of HIV in the country. It has all sorts of biologic measures, including fibroscans and 2 rounds of PEth testing. So this is a study that's about to start as part of our new P60 study center called the Caliber. So now I'm going to shift and talk about what we can do about the alcohol use in persons with HIV. So there's significant harms. We're finding significant harms of alcohol use, not a surprise. And so we and others have tried to develop interventions that could be potentially integrated into HIV care. So I'm going to summarize some of the approaches that have been tested, talk about the results together that have found consistent, significant, but modest effects, and then talk about what happens when you measure using PEth, when you measure the efficacy using PEth. So here's sort of the crux of some of the interventions that have been done, and I couldn't list all the references to that because there are many. Fortunately, NIAAA has been interested in funding alcohol interventions for people with HIV. Many of them have been counseling based, so that with an eye towards potential scale up. So there have been lay counselor and technology delivered brief interventions. They've been interventions building on, the wealth of alcohol interventions out there in high resource settings like MET, CBT, motivational interviewing, and acceptance and commitment therapy. And then newer things are coming on the horizon. Amy Conroy, who I work with, has been working on couples-based interventions and now starting to include biomarker-based feedback, and that's part of our Caliber Center as well. And Sarah Wolf-King and colleagues, Amy's also working with Tyrell Starks, and Sarah Wolf-King and Julian Shear are working on leveraging alcohol and trauma-based interventions together to address comorbidity of unhealthy alcohol use and PTSD in women with HIV. Another vein of alcohol use interventions that I think are interesting are trying to apply things like contingency management or contingency management light. We did a study looking at incentives for reducing alcohol use based on an alcohol biomarker, the urine test, which is actually our only point of care alcohol biomarker. Should have mentioned that before. But also other behavioral economics based interventions include Susan Keene and team's work on mobile money and savings, because people are spending, especially in the community she's working, people are spending huge amounts of their income on alcohol. And if you help them save their money, they may spend less on alcohol. And she's combining that with motivational interviewing. And then Amy Conroy and her couples work is thinking about the financial literacy and savings with Fred Semawala. And then, of course, there are pharmacologic-based interventions for people with HIV. And these are the studies that have been done, also collecting alcohol biomarkers. I know there have been other studies as well, many prior studies looking at varenicline and cytosine, thinking about tackling smoking and alcohol use at the same time, because those seem to affect craving. Naltrexone, there's a study of gabapentin being conducted in Uganda, previously in Russia. And thinking about doing pharmacologic interventions using stepped care so that you step up through the more increasingly intensive interventions. And that's work with Jen Edelman and Dave Filene. So given all these great interventions that have been funded, and given that I've been talking about biomarkers for quite a few years now, all those, a huge number of studies, a large number of studies actually started collecting the PEth biomarker. So we thought, well, what is the sort of joint efficacy of alcohol interventions for people with HIV when you measure it using the PEth biomarker, given all our hesitations about self-report before? And I was especially concerned about behavioral counseling type interventions and self-report when you're being counseled to reduce alcohol use. You might be even more likely to report you're reducing alcohol use. So I was concerned about our self-report findings. So I wanted to know what's the efficacy by PEth, and then how does that compare to self-report? So we conducted a systematic review and individual participant data meta-analysis, meaning an IPD meta-analysis means that you get the raw data rather than just grabbing the odds ratios from the abstracts or from the articles. So we did our systematic review, reviewing the academic literature and clinicaltrials.gov in 2023. The studies that were eligible included adults, people with HIV, at least 30 people with HIV, and were conducting some kind of intervention to reduce alcohol use, and they had to measure alcohol use by PEth and self-report. And in our review, we found 20 studies, and we were able to get the raw data from 16 of those. We conducted 2-stage modeling, grade rating, and publication bias assessment. And our main outcome was unhealthy drinking at 6 months. And we measured that using a PEth score or a self-report score. And using the self-report score is under the assumption that people don't tend to over-report their alcohol use. And so by combining these two measures, we get an even more sensitive measure of unhealthy alcohol use. So what did we find? We found, in our 16 studies, we had a pooled odds ratio of 0.69, suggesting that there was an effect of the interventions on unhealthy alcohol use that basically, if you were in the intervention arm compared to the control arm, that was protective for unhealthy alcohol use at 6 months. And the I-score is 29. This is not a huge effect. This is a modest effect. This is actually similar to the effect found in a meta-analysis in 2017 where they didn't use biomarkers or IPD meta-analysis. So that's a little bit interesting. When we compared it to just using PEth alone and not trying to combine having our composite score, the odds ratio did move closer to 1, meaning that it was a little bit of less of an effect seen, but there was still an effect seen that was statistically significant. And there, the I-squared, the heterogeneity measure was 5.7%. And then when we looked at self-report alone, we used the audit C. Most of these studies had used the audit C. If they didn't use the audit C, we tried to transform the self-report to audit C. We again found the same effect size of 0.66, similar to our composite score. So that was quite interesting that we didn't have a difference in result, even though we thought we would. What we did see was different, and we think is important, was this I-squared jumps up to 68.7%, saying that there's a lot more heterogeneity when we use the audit C. So that's important, that we feel that when you're trying to measure something, it's nice to have a measure that is going to be fairly consistent across studies and not have the heterogeneity that you get when you do self-report. We did also look by several subgroups. We looked to see if the intervention was, if the intervention effect was different by male, female, by level of alcohol use at baseline, by setting. And we didn't see any major differences, although I would say the effect tended to be a little bit stronger in people in the low resource settings and people with lower risk alcohol use at baseline. We're starting at unhealthy alcohol use, but we were accepting the whole range so that people at the much higher level risk was somewhat less of an effect, but still an effect of the interventions. So to summarize what we've learned so far, that alcohol use plays a large role in HIV comorbidities, and measurement is important. And we're, self-report is great, but we have a bias problem. Objective measures add consistency, And I would say that the efficacy of the alcohol interventions is promising, but is modest. And then, of course, we haven't gone on to the real world effectiveness. So going on to what I think the future might be, I'm quite interested in leveraging alcohol biomarkers for implementation. And what I mean by that is that alcohol biomarkers so far have been used as a research tool. But what about as part of the interventions or as part of clinical care? They do have the potential to increase self-awareness of alcohol problems. They could be useful for goal setting and motivating change. And it could be similar to people receiving their CD4 counts, their ART adherence that's now being tested in urine, or their HbA1c when they have diabetes. We are doing a study thinking about how to best communicate PEth results. It's a little bit tricky. It's not as easy as talking about HbA1c. And so we have worked on developing scripts working with key stakeholders to determine how to deliver the results. And so far, it's seemed as acceptable, and increases awareness of alcohol use and its health effects. But we do feel like it needs to be delivered well, and we've been developing culturally relevant scripts, and especially the participants have been especially interested in having good visuals. So this is our visual that we are going to test out fairly soon. In the US, Marianne Piano, who I think is there at Vanderbilt, or was there at Vanderbilt, started some work looking at giving young adults their PEth results. And a paper came out this week from Alan Scheinfeld looking at giving people PEth results. They were doing remote PEth testing and giving people who have people with HIV with unhealthy alcohol use and mental health problems, they were giving them PEth results. And I think it was shown so far to be feasible and acceptable in this small sample. So that's really very exciting. We're also doing a survey looking at people's attitudes towards alcohol use in the US, and just thinking about how do people like talking about alcohol use in their healthcare? Would they prefer a blood test? Would they prefer the blood test over the talking about it? And so we're doing a sort of online study, which will be interesting. Look forward to reporting on. And then lastly, just a plug for our excitement, I guess, about our new center. It will leverage advances in alcohol biomarkers to reduce the harmful effects of alcohol use on HIV, transmission, and comorbidities. We have innovative behavioral interventions and translational research, a dissemination core with community engagement, and we are training, plan to train the next generation of investigators, and we are going to be having calls for pilot grants. So we have some part of the funding goes towards pilot investigations. I think I'm going to skip the summary because out of time, but I just feel like the next steps, we can still improve the measurement. Point of care PEth is the pie in the sky. We would love to have that. Right now, it's not happening, but keep pushing for it. We do need a little bit more knowledge about cutoffs. Potentially, there may be some potential for personalized cutoffs, and there may be potential for integrating PEth testing with routine labs in clinical care in general. In the intervention world, I'm quite interested and think that there's a place for biomarker-informed feedback. We have it in other areas. Why not in alcohol use? And it could be part of personalized or adaptive interventions and combined approaches. And then implementation, we really need to push towards getting these interventions from our efficacy studies into routine care, screening, intervention, HIV, and other clinical care. Maybe even outside of care, what's going on in the community, what are people doing online, and then thinking about scalability. And with that, I want to thank the many collaborators, teams, funders, and study participants. Definitely call out my work in Uganda. I was welcomed by Mbarara University and Dr. Winnie Muyindike, and my team at UCSF is led by Neka Eminyanu and Robin Fetch doing all the analyses. Thank you.
Thank you, Judy. That was fantastic. We don't see any other questions in the chat yet. Do people want to simply just raise their hands? I know we've got a good number of folks. It's probably the easiest way to do it.
I see
Hey.
Deepali.
Yes,
Hi.
that's my name. Hi, Dipali. Nice to meet you.
Hi.
This was thank you so much for this talk. This was really great. I, for some reason, so I do personalized normative feedback work as well, and I was somehow under the impression that that PEth was really only sensitive for any alcohol use. I never really, I had not heard really until now about its use in identifying or being more sensitive in identifying heavier alcohol use or more problematic alcohol use. So that was really, really interesting. And I'm just curious as to whether these slides were going to be made available, especially with regards to some of the studies that are already kind of starting to do this work and incorporating it into feedback interventions.
Yep.
Perfect. So not a question, just a comment. Thank you so much. This was very
Yeah,
interesting.
I would say that in terms of, say, like addiction treatment, the people who are actually ahead of us, that's not HIV, is the Europeans.
Mm.
They've been using PEth testing a lot, and they don't really write about it a whole lot, but I know that they're using it. So hopefully they'll be writing about it some more. But if you want to email me, I can tell you some other there is one paper from Sweden, and the liver people are also using it a lot. That's actually the sort of almost scary point, because they're not sure how to use it, but they're using it in the transplant setting.
Very interesting.
Yeah.
Yes, please, if you wouldn't mind sharing your email, I will definitely reach out. Thank you.
Sure. Oh yeah. Sorry, I didn't put it on the slide, did I?
Do we have other folks? I know we've got a few people that work in the alcohol and HIV kind of group with Matt Freiberg here. Okay. Perfect. Well, I think we've got a lot of folks also that are going to be probably watching this when it's recorded, and it'll be on, it's our internal CFAR website for people that are in clinic this afternoon. So I think if they have questions, it's probably is it okay to reach out and ask?
Sure. And if you have criticisms too, like I'd love to, happy to kind of, put things out there and see what the reaction is. Because I do think that sometimes when I talk about PEth, it's a little loaded, it's to have someone come back with, to you with a number that this is how much, this lab test says you've been drinking. How does that work? It's a little tricky. But I think, yeah, I'm excited about its potential, but I'm always happy to hear too people, especially people working in the field, what their, thoughts and experiences are.
Yeah, I work in the VA system, and that's not something that we have used, too extensively in our veteran population in clinic, but it is something that I wish we would use more often. We quite frequently run across individuals who clearly, have an alcohol use disorder. They're even sometimes enrolled in VA programs, and yet, the response to us in clinic is constantly, "Oh no, absolutely not. Everything is going well."
Yeah, and I think some of the work within the VCC, where we've done studies and had a lot of people have positive PETs, even though their audit score would not indicate that. It really highlighted the need to do better screening in the clinic to see if we're missing people who have alcohol use disorder.
Yeah, I think that's true. And I should mention, Judy, I don't know if you've met Kirk before, but he works quite a bit with Matt on the final study, and also is running separate clinical trials looking at different probiotic and fiber formulations to improve non-alcoholic fatty liver disease, of which I'm assuming probably some folks in there probably have alcohol too. Kurt, have you done PEth scores in those people?
So for my GLAM trial, yeah, everyone's getting a blood spot and we're measuring PEth. And I'm definitely experiencing underreporting of alcohol use.
Okay.
In the clinic, especially in the liver transplant area, PEth is like candy to us. We order so many PETs. I've probably ordered a couple hundred since I've been a fellow.
Yeah, I think the trials are starting. I mean, I was keeping my eye on the GLP-1 receptor agonist trials, and they are measuring PEth, and I'm happy to see that. What happens though is when you have a trial result, like an individual trial result that's different between self-report and PEth, what do you do about it? You know, my first study, I had that result and I had to say, I don't think there's an effect here, you know, and then, you know, all these other studies, you know, did actually, you know, show an effect. So, you know, who knows, but
Yeah.
I mean, who knows is actually, I do think I know, but I don't want to, I was disappointed that, you know, we were seeing this great, you know, signal by self-report and not such a signal by PEth.
Yeah.
But it's, yeah.
Yeah. I mean, the problem with a chronic disease like cardiovascular disease and ALD is, you know, PEth is just a snapshot. And it doesn't really, you don't really know the area under the curve over several years of alcohol use. So maybe self-report is better. I don't know.
Well, some PEth people I work with are very, very stringent about, you know, one PEth result doesn't really mean a whole lot, but that the trajectory of it is what's meaningful. I do also think that I was sort of saying this is a whole other talk, you know, PEth is a reflection of how much alcohol you're metabolizing. So if you're better at metabolizing alcohol, maybe you have a lower PEth score. And so sort of an absolute PEth number may not translate directly to number of drinks. It may translate to the harm to your organs, so, you know, maybe we don't even need to talk about numbers of drinks. We could just talk about PEth scores. But over time, definitely, I agree with that.
Is anyone aware of any, and I'm sure this exists and I just don't know, but any large population-based databases that contain information with PEth, maybe that are sponsored by NIAAA or anything like that?
So this MaxWise cohort that we're basing our Caliber study has now tested everyone once and is on the second round. So and we're going to be looking for pilot studies, secondary data analyses, definitely in that. And we have that data. The VAX study did a round of PEth testing a pretty long time ago. I say it's going to be more and more. It's going to be more and more. And actually, I've been sort of plugging my sort of data colleagues that are really good at like scraping out data, you know, into, you know, if it's starting to be used in clinical care, say in liver clinics, what can we scrape out of EMRs? We're not going to have any like really good, we don't know how good the self-report is, but if we want to just equate it to say like clinical outcomes, that would be, you know, that to me is also sort of a next step. And when I've talked to people at UCSF, there's a big UC, University of California, data repository of EMRs, and they say so far they don't want to go in there, but I'd say in a few years we probably could go in there, and then we could just go directly from PEth to clinical outcome, and I actually think that might be where we need to go. But in terms of talking to patients, we still need to have something to say about, you know, how much you're drinking, I would imagine.
And locally, Matt Freiberg will have a couple hundred people with PEths from the VCCC. And yep. my little trial will add another 60 or so.
That's great. Yeah, keep in touch when we, you know, if someone wants to do another meta-analysis of, you know, I think that was pretty exciting to be able to get the data that we had, but there's probably next steps after that too.
Right. Well, I think we're at the top of the hour. Heather, could you put up the NCAP slide if you could? And Judy, I just wanted to thank you for coming and talking to us and for a wonderful presentation. We had a great audience. And again, just so folks are aware, this will be posted to the CFAR website internally for those who would like to view it later. And thank you again for joining. We are going to have another seminar next month, and then in June. I think we'll take a break in July, but next month, it'll be Latrice Pichon from University of Memphis, a member of our CFAR, in addition to Andrea Stubbs, who also works in Memphis and also with Latrice. And they'll be talking their talk will be entitled "Leading by Igniting Faith and Education to Tackle Stigma." So hopefully everyone can tune in as well. So thank you again, Judy, for joining our seminar series. And hopefully if people have questions, it sounds like they'll be reaching out to you.
Thanks a lot. Take care.
Okay. Take care, everybody. Thank you.
Bye.